see my screen?
Yes,
You
Doc.
can.
So from all right. So we're talking about chronic obstructive pulmonary disease, COPD. COPD is still a problem because no matter, people still smoke. Okay? And the number one cause for chronic obstructive pulmonary disease is cigarette smoking. Unfortunately, we have now replaced cigarette smoking with vaping. Vaping is a problem. And vaping started off because in an effort to get people to quit smoking, we started with the sexy electronic cigarettes, which look so sexy, and they got away from all the carcinogens you are inhaling. So you look so hot with this, but you got the nicotine, which is the addictive substance. The problem is we have moved beyond the sexy cigarettes. We are now using other stuff with the nicotine. We're using THC, we're using everything else. And the liquid that is being used for vaping can be harmful to the lungs. So we're in another predicament. But cigarette smoking is one of the main causes of chronic obstructive lung disease. What is the big deal about COPD? What is everybody excited about and making all of this? And it's not just Jamaica and the Caribbean. It is a worldwide problem. Chronic obstructive disease is a little known disease. It is confused with asthma. And we just went through where we talked about the fact that asthma is reversible. And we spoke about the fact that we're looking for this reversibility. If we do, and we get FEV1 upon FVC, even after I use the bronchodilator, FEV1 upon FVC is less than 70%. That is irreversible. That's COPD. We are so we can differentiate it from asthma because it loses there is no reversibility. Then, on top of that, we know cigarette smoking is the number one cause. But cigarette smoking only causes lung cancer. Sure, man, no big deal. But COPD is a lung disease, an obstructive lung disease caused by chronic cigarette smoking. And lung cancer, unfortunately, overshadows COPD because many people don't know nothing about COPD. Most patients will be diagnosed with COPD when they reach 60 or 70. So in the 60s or 70s now, they smoke and enjoy the nicotine, which is the greatest thing since sliced bread, for so many years. It was just wonderful. You know, after dinner, after you had a cigarette, it was the most wonderful thing ever. But when you reach 60 and 70 now, you start to have coughing, you start to have chest tightness, you're bringing up sputum and you're short of breath. And it's obvious that something is wrong. This is when you're going to do your spirometry and recognize that you have developed COPD. Because what has happened is that now in your 60s and 70s, when you start to cough, have the chest tightness and shortness of breath, you have already had structural and functional changes in the lungs caused by the inflammation induced by cigarette smoke. So you have enjoyed the nicotine, felt wonderful to hang out with your friends, but over the years, the cigarette smoking has caused airway inflammation, which when it starts to manifest in your 60s and 70s, you're in trouble. You are now totally symptomatic because so much structural damage has been done. And at this point, the cigarette smoking has not only done damage to the lungs, but it has done damage in other organs. So it has accelerated atherosclerosis. So you have heart disease. It has accelerated atherosclerosis. You have peripheral vascular disease. So you, at this age in your 60s and 70s, COPD is associated with these other comorbidities, and you're in trouble. What is a big deal about COPD? Cigarette smoking is preventable. You don't have to smoke cigarette. It might look cute, it might look sexy, it might make you look nice, but you don't have to smoke cigarette. And it is highly addictive. So, whereas we keep on talking about recognizing the structural damage in your 60s and 70s, when you start to get the shortness of breath and you start to get the chest tightness and the cough, the problem that we face, especially in Jamaica, is that we are smoking much earlier. We're smoking from about 12, 14. And then what is very popular, whereas cigarette smoking may not be as au fait or as sexy with young people, it's grabber. Grabber can be either the tobacco leaf with the marijuana, or grabber can be the pulverized cigarette with ganja in the Rizlo. So, and we are starting early and we're consuming a lot of grabber. So we need to recognize.
Abigail, your mic is open.
So we have a problem. We're starting young, and if we continue this rate of consumption, we may not have to reach 60 and 70 before we start to see the health issues. It might come earlier. So we need to recognize that COPD is a preventable disease from cigarette smoking. We need to recognize that it comes with a lot of comorbidities. We need to educate the young people to move away from the smoking. And we also need to recognize that those of us who don't smoke and you continue to expose us to cigarette smoke, you're also putting us as non-smokers at risk for COPD. Everybody with me? Everybody with me?
Yes, Doc.
Yes, Doc.
All right. So, just as how we spoke about the gospel for asthma is GINA, Global Initiative, now we talk about the gospel for COPD is GOLD, the Global Initiative for Obstructive Lung Disease. So GINA is to asthma what GOLD is to COPD. So there is actually a GOLD 2024, I think, which is online. And it defines chronic obstructive pulmonary disease as a heterogeneous lung condition. The patient has chronic respiratory symptoms of shortness of breath or dyspnea, cough with sputum production, and they have periods when the shortness of breath and the coughing and sputum production increases. Those periods are called exacerbations. The dyspnea, the cough, and sputum production are due to abnormalities in the airways, bronchitis, bronchiolitis, and also in the alveoli, because there is elastase released in the lung, which causes destruction of the lung parenchyma. All of that leads to this persistent, progressive airflow obstruction. So the goal definition, the hallmark, chronic respiratory symptoms, dyspnea or shortness of breath, cough with sputum production, and exacerbations, periods when it just gets worse due to abnormalities of the bronchi or the small airways, bronchiolitis. So you get airway inflammation in the bronchi and the smaller airways. And there is elastase production, which leads to destruction of the pulmonary parenchyma. So they get the bullous emphysema and those things. So between the airway inflammation, the symptoms, the chronic respiratory symptoms, the destruction of the alveoli and the interstitium, the patient has persistent progressive airflow obstruction. And the Global Initiative of Obstructive Lung Disease is a document that's on the internet, and it's really done well. No. Chronic bronchitis. What is chronic bronchitis? Chronic bronchitis comes under the umbrella of COPD. And there is actually a definition for chronic bronchitis. The patient with chronic bronchitis is defined as having cough and sputum production for 3 months for 2 consecutive years. Pause. I have some patients who, remember I told you that the period for exacerbation of asthma was from about October to about March, April of the following year. So you have some patients, oh yes, doctor, I have bronchitis. But if every single year, November, December, when you get a viral infection, you're having coughing and wheezing, this might be asthma rather than chronic bronchitis. So you ought to do your spirometry. So the patient has mucus hypersecretion, they have airflow obstruction, and they will have the increased exacerbations. Chronic bronchitis may be seen in younger adults who smoke, but it is more often seen, chronic bronchitis is seen a lot more in marijuana smokers. So it is said that people who smoke a lot of weed, they tend to have more chronic bronchitis. The cough, the mucus production, the hypersecretion of mucus rather than emphysema. Okay? Now, pathogenesis, causes, and risk factors. The most important thing is cigarette smoking. And it comes over an extended period. You get the cumulative response of the exposure to cigarette smoke, causing the airway damage and the airway inflammation. People who smoke cigarettes have a rapid decline in lung function. Cigarette smokers have a higher prevalence of respiratory symptoms. Them cough and them have more mucus production. So you talk about a smoker's cough, and in the mornings in particular, they talk about this clearing of their secretions. Cigarette smokers have a higher prevalence of lung function abnormalities. When you smoke cigarette, you have a greater decline in your FEV1 than somebody who does not smoke. So if I smoke, my FEV1 going to decline at a faster rate than somebody who does not smoke. If I stop smoking, I halt the rate of decline in the FEV1. I slow it down. Cigarette smokers also have a greater mortality than non-smokers. And do not underestimate the passive exposure to cigarette smoking. We are not to be deprived of our rights. I don't have to be sitting down and inhaling your cigarette smoke and your ganja smoke, okay? It will also cause a cumulative effect on my lungs. So if I have a boyfriend or a husband who smoke, grounds for divorce. Because, and I say that jokingly, but I actually had a classmate, and I did not say, who was a smoker, heavy smoker, got married to this young lady who in her latter years developed lung cancer. She was never a smoker. And when he realized that her risk for lung cancer was because of his continued cigarette smoking, he got extremely depressed. Worst of all, she died. So passive exposure to cigarette smoking is real and it has effects. Now, other types of tobacco smoke will also cause COPD. So the people who smoke pipes, the people who smoke cigars, when you go to these Mediterranean restaurants and they have the hookah and they pass it through water, you will still get COPD. And people who smoke marijuana are still at risk for developing COPD. But we said they tend to develop more the chronic bronchitis. But there is a special group of people who will develop COPD and them not really smoke. So in situations where I burn a lot of wood repeatedly for cooking, in a closed environment with the burning of wood, where I burn crop residues or I burn coal and I'm continually exposed in an enclosed environment to the burning of the wood, the charcoal, I am still at risk of developing COPD. So poorly burning with stoves in a poorly ventilated environment, I'll get high, those poorly ventilated environments will give me high levels of household air pollution. Now, we burn coal in Jamaica to cook. We use enough wood fire. But what we found in the majority of cases where coal burning was used to cook or wood fires were used, it was usually in an outside kitchen. So the ventilation was not a problem. It was a better ventilated environment. So the risk in our setting was not high from burning of coal and wood fires. Then you had the occupational exposures to organic and inorganic dust or to fumes from chemical agents, people who work in cement, people who work in bauxite, people who have to work with these fumes. And don't knock it, as simple as air pollution, chronic exposure to particulate matter about 2.5 micrometers can cause airway inflammation and COPD. So these are some of the other risk factors for chronic obstructive pulmonary disease. Cigarette smoking, marijuana smoking, cigarette smoking remains at the top of the list. Marijuana, pipe, hookah are all risk factors. Don't forget as well, chronic air pollution and burning of wood and coal regularly in poorly ventilated environments will lead to COPD. COPD is a public health concern because it is reversible. We talk about the exposure as well to people who are non-smokers. So we were supposed to enact legislation to reduce smoking in public places. GOLD now even breaks it down into pre-COPD and early COPD, which you can look at in the GOLD guidelines. But the most important step is to encourage people to stop smoking. It is the most important thing. So wherever the opportunity comes for you to see patients and they tell you that they are smokers, remember smoking is described in pack years, the number of packs per day for the number of years. A pack is usually 20. So if I smoke 10 cigarettes is half a pack for 20 years, that's 10 pack years. Always use the opportunity to encourage smoking cessation. Not everybody can stop smoking cold turkey. Some people need help, whether it is the nicotine patch, and that's how the e-cigarettes came out, because you would get the nicotine in the e-cigarettes and avoid the other carcinogens from tobacco, whether it is with Wellbutrin and the nicotine patch, whether it is with Chantix, which is going to deliver dopamine in the brain, but we can't get Chantix locally. You need to encourage your patients to stop smoking. Now, how am I going to diagnose COPD? Now, I need to be able to get my history of cigarette smoke or whatever the exposure is. But in managing my patient, I need to be able to maintain stability in the patient. I want to reduce the exacerbations in the COPD patient. I want to reduce the episodes where the cough gets worse, the sputum production gets worse, the shortness of breath gets worse, because each exacerbation that the COPD patient gets increases their risk of a myocardial infarction. So they found that if the patient had COPD, the more exacerbations the patient got, was the greater the risk of them having unstable angina, acute myocardial infarction, even stroke, within 30 days after the exacerbation and up to 1 year after. So my management as the physician looking after the patient with COPD is to keep them stable, reduce their exacerbations, because each exacerbation up to 30 days after the exacerbation are putting them at increased risk of heart attack, cardiovascular events, and up to 1 year, the risk is great. So my job is to diagnose and properly manage and educate. Then I need to do my spirometry because COPD is diagnosed with spirometry. FEV1 upon FVC less than 70% even after I get my bronchodilator. I will look on my chest x-ray and I will see my hyperinflation, or I do a CT chest and I get cystic lung spaces and all of that on my CT chest. I need to treat my comorbidities because remember, we said it's coming in the 60s and 70th decades of life, 6th and 7th decades of life. So if I've been smoking, if I have a 30, 40 pack year of smoking, that are not only going to get changes in my lungs, but we spoke about the fact that I'm going to get advanced atherosclerosis. So I'm going to get peripheral vascular disease. I have set up for cardiac disease. I have set up for stroke, and I have set up for erectile dysfunction. So I need to manage the comorbidities. Another thing that's important, I need to immunize my patient. So they're supposed to get them flu shot to reduce the exacerbation. They need the pneumococcal vaccine to reduce a pneumococcal pneumonia to reduce exacerbation. They need to get them pertussis vaccine to reduce exacerbation. And they need them COVID vaccine to reduce getting COVID. Because all of those things is to keep them well and without exacerbations. And where possible, I teach the patient how to breathe so that the distress is less. Now, I diagnose COPD with spirometry, but spirometry is important to give me an idea of the severity of the airflow obstruction. So spirometry classification is still important, but we now know that COPD is so much more than spirometry, is enough more. But it is important to diagnose a chronic airflow obstruction measured by after I nebulize with salbutamol, FEV1 upon FVC still less than 70%. So I can break it up into stage 1, which is mild airflow obstruction. The FEV1 is greater than 80% predicted. Hard to convince that patient to stop smoking. Stage 2, the FEV1 is between 50% to 80% predicted. That patient is going to be symptomatic. They're going to be having cough, short of breath, them can't keep up with the other people. Physical activity requires a bit more effort. Goal stage 3, where the FEV1 is less than 50% predicted, that one is clearly symptomatic. And the very severe airflow obstruction, goal stage 4, where the FEV1 is less than 30% predicted. When that patient go out to the road, they can't breathe, that patient invariably requires home oxygen. Everybody with me, or I'm talking to myself? Hello?
Doc, you can just go back over the stage 2, please.
Stage
We're
2.
with you, Doc. We're with you.
Oh, you wait. Oh, thank God, because I'm getting hungry and thirsty and I feel like I'm talking to myself. Goal stage 2, we're talking about, we know that COPD is more than spirometry, but the spirometry is still useful to give me an idea of the severity of the airflow obstruction. So the goal stage 2, the FEV1, take a deep breath in and blow. The FEV1 is between 50 to 80% predicted. That patient is symptomatic. They will have some amount of shortness of breath and chest tightness. The gold stage 3, the FEV1 is less than 50% predicted. That patient definitely short of breath, can't keep up with his peers in walking, and I'm sure has marked shortness of breath with exercise. If you reach gold stage 4, your FEV1 is less than 30% predicted. That patient will need home oxygen because them can hardly breathe. But this is just airflow on spirometry. We know that COPD now is much more than airflow, but this is still useful in helping us to categorize severity. This was put on because this was a spirometer we used when we were doing the BOLD study locally. Notice this spirometer is the NDD spirometer, which we took out with us into the field to measure the airflow and to assess the patients. It's a very sensitive instrument and it's very robust. What she has in her mouth is a spirette. And notice the nose clips so that all the airflow, she take a deep breath in and blow. Everything that she's exhaling is going to be measured by the spirometer, and there will be nothing coming from her nostrils because of the nose clips. So everything will be measured by the spirometer to tell us or give us an indication what her airflow is like. So this is a portable handheld spirometer, which was used by all the participating countries in the BOLD study, the burden of obstructive lung disease. It takes a lot of work. It is not easy because you want to be able to get good flow volume loops, which are reproducible. And we showed you this for asthma. This is what the flow volume loop looks like. Take a deep breath in here and blow. So the yellow curve is for the patient who has normal airflow, no airflow obstruction. And the blue or green is for the patient who definitely has airflow obstruction. You can see the scooped out appearance. Now, we already said that COPD spirometry is useful, but we already spoke about the fact that COPD is more than just spirometry. They have shortness of breath, and the shortness of breath is a significant component of the COPD. It affects their quality of life. Now, what we need to do is to know how to evaluate shortness of breath, and there is a scale called the modified MRC scale, which evaluates shortness of breath. And how this comes in is that when we are going to categorize COPD, when we're going to put them in class A, B, C, or D, we use spirometry, we use a level of dyspnea, and we use the quality of life score, the CAT scores, the three things to decide how severe this patient's COPD is and what class to put them in. So we looked at Spiro and we went through the stages. Now we need to evaluate dyspnea. So you have grade 0 if I only get breathless with strenuous exercise. So if I go run around the dam and get breathless, that's okay, grade 0. If when I'm hurrying to go from the car park or walking up a hill, I get shot, that's grade 1. If on level ground, just on level ground, I walk slower than people my own age because I get breathless or I have to stop for breath, that's grade 2. So, you know, when we looked at this one, from you reach grade, this patient must be short of breath walking on level ground, the stage 3, and they may begin to be symptomatic by stage 2. So we're talking, and so grade MMRC grade 2, I get short of breath walking on level ground or if I have to stop for breath when walking at my own pace. Grade 3, I stop for breath after walking about 100 yards. Or grade 4, I am too breathless to leave the house. So notice the patients who are bad, who are very short of breath, are from we reach about grade 3 to 4. Grade 2, not so good either, grade 2 to 4. Okay, so this is a modified Medical Research Council scale for evaluating dyspnea. So I'm putting my COPD patient in a class based on the modified MRC scale, the spirometry, and another score called the CAT score. Okay, let me see who is with me now. Good.
Doc,
Yes,
question.
go
You
ahead.
don't do the the post bronchodilator test as well to assess airflow obstruction.
Yeah, that is how I made the diagnosis of COPD. Because after I
Oh,
gave them the bronchodilator, the FEV1 upon FVC ratio, even after the salbutamol, was still less than 70%. That's how I made the diagnosis.
oh, so it's a part of the spirometry?
Yes, it is. So when you do
Oh,
spiral, no, hello, look like I have to go back here now. Come on, let's go back. Good. So when you come for spirometry, and I take your height and your weight and stuff, I ask you to take a deep breath in and blow. And I measure your FEV1 and I measure your FEF 25, 50, and so on. Good. Then I nebulize you or I give you 2 puffs of salbutamol. We give it to you through a spacer, and I wait 20 to 30 minutes, and you come back and you repeat the test. Put you on the spiral. I said, take a deep breath in and blow. When you do it, your FEV1 upon FVC improves from 12 to 15%. What you have, asthma or COPD?
asthma.
Exactly. But I put you on and I nebulize you or give you the 2 puffs. When I do it, FEV1 upon FVC still less than 70%. Improve maybe by only maybe about 5 or 6%. Is that asthma or COPD?
COPD.
Because there is irreversibility. So that's why so the spirometry is important to diagnose. And the diagnosis is made when the FEV1 upon FVC after the salbutamol is still less than 70%. Okay, is that clear? Clear?
Yes, Doc, clear.
So let me tell you who is going to look at who can tell me what is going on in this. This is a 50-odd-year-old taxi driver who has now stopped smoking, who FEV1, he is stage 3 or stage 4. Let me see what he's at now. Tell you what he's at. He's at stage 3. No, he's stage 4. His FEV1 is less than 30% predicted. He uses home oxygen and he comes into hospital because he has worsening of his COPD. Why is he having worsening? What's going on in the left lung? Oh, it's on the screen. Sure.
That could it be due to some exacerbating factors, perhaps?
He has an exacerbation, but what is the cause of his exacerbation? It's on the screen.
It's it infiltrates.
Yeah, it infiltrates in the left base. This is where the pneumonia is. Right, you can
So
see.
say he had a pneumonia that exacerbation.
Precisely, he had a pneumonia that has caused his exacerbation. But look at what happens on this side. So he comes into hospital another day with tearing chest pain and can hardly breathe. When you look, you notice how black this is? You notice
Yes,
how
Doc.
bully. This is bullous disease. This is bully. You have no long markings going out here. He has bully here on this right side and also up here. So he has bullous emphysema.
Hi, Doc. Is that because the air is being trapped in the small alveoli?
That's right, because of excess elastase production. So it has destroyed the lung parenchyma and given me these bullous changes.
Okay. All right.
Okay, so this is bullous emphysema, exacerbation because of infiltrates over here, but he has bullous disease from chronic cigarette smoking, air is trapped, and elastase production has destroyed the alveolar wall, so he has air trapped in there. He has bullous emphysema. Okay, and the lateral, this is the increase, this is the sternum here. Notice the dark here, the increased retrosternal airspace, and all the black round here from the bullous disease and hyperinflation. Clinically, when I go to examine him, he would have loss of cardiac dullness and loss of liver dullness because of the hyperinflation. So normally my liver dullness should start by about the nipple. He not have no liver dullness because of the fact that he's so hyperinflated. Okay? So we talk about the classification of COPD, and this you can read on the GOLD guidelines, because what we have now found is that classification of COPD, we either use the A, B, or E assessment tool. So we use the classification is based on other parameters beside the FEV1. We need to assess the degree of dyspnea. Remember, we spoke about the modified MRC scale. We want to assess the frequency and severity of exacerbations, because remember we said the more exacerbations, the greater the risk of cardiovascular death with up to 30 days, within 30 days or up to a year. And the rate of death from COPD increases with the frequency and severity of exacerbations. Exacerbations may be either mild, moderate, or severe. An exacerbation can come from bacterial infection, like in this gentleman, or it can come from viral infection or exposure to different pollutants. So GOLD, Global Initiative for Lung Disease, uses either you put them in class A, class B, or class E. Now, I don't want you to get bogged down, but the CAT score is something that we use to assess the severity of your COPD and the impact of the COPD on the patient's life. So the two scales, the modified MRC scale to assess the degree of shortness of breath, and we said that the MRC scale, when you reach from about grade 2 to grade 4, you're bad. In a similar way, the CAT score asks questions about 8 areas. How often I cough? Because remember, the hallmark is cough sputum production. How much mucus in the cough? How much chest tightness? How out of breath do I feel? How much does my condition limit my activities at home? How comfortable or safe do I feel leaving my home? How well do I sleep? So the CAT score, each area gets a score of 5. There are 8 areas, each area gets a score of 5. So the maximum is 40. If a score 0, there is no impairment in that area. So the overall score is 0 to 40. A score of 5 means significant impairment. So if my score is the lower my score, the better I am, is the less impact of the COPD on my life, the lower my score. The higher my score, especially the closer I come to 40, is the more my quality of life is affected by the COPD. So the two scales is the MMRC and the CAT score. So group A, 0 to 1 exacerbation, but no hospital admission. MRC, modified MRC 0 to 1. CAT 10, a good man. I'm good. I can be in group A, and you can treat my COPD with a long-acting beta-2 agonist by itself.
I'm sorry, Doc.
Yes.
Before we move any further, you said that for the CAT score, it's either a parameter receives a score of 0 or the receiver score of this a range.
So the CAT score, each of these 8 areas, the score will be 0 to 5. 0 means nothing happened to me. I'm not coughing. No mucus not upon my chest. I don't have no chest tightness. But if I go up to a 5, it means I'm coughing and I have significant chest tightness. If that is the case, the higher my score, when I look at the 8 parameters, the higher my score is to 40, it means the greater the impact the COPD is on my life. I have poor quality of life from the CAT score.
Okay.
The lower my score, it means that, all right, I'm managing, I'm okay. The COPD has not had a profound impact on my quality of life.
Okay, so I guess my question is, is it subjective where for the first question, like you ask the patient the severity of the cough, they can say it's either a score of 0, 1, 2, 3,
That's
or
right. That's right. So they actually have something printed that they can tell you about. Yes. Just
okay,
like
understood.
just like the act for the asthma, something like that. Remember the asthma control test that we spoke about when we're talking?
Yeah.
So something like that. So the higher the score is to 40, the worse the COPD is on my overall health. The lower my score, all right, are coping. Okay? So when we put in the patient into any of the classes, A, B, or E, group A is a good patient. CAT score low, the modified MRC scale 0 to 1, them functioning. So that patient with COPD, I can use a LABA alone to treat. Gold group B, still few exacerbations. CAT's MMRC score is greater than 2, so they're shorter breath. They're shorter breath with some exertion. Remember, this one said 0 to 1. So the shortness of breath is there. So I would use, and the CAT score is greater than 10. So there is some effect on the COPD on their quality of life. It's less than 10 in A.
Doc,
It's great.
I have a
Yes.
question. Since we're using these scores for the patient who has the FEV1 greater than 80 and he was mild, is it that that person was diagnosed with the post bronchodilator, but they were diagnosed in a different way?
They have a history of smoking, and as it is, their FEV1 upon FVC may not be less than 70%, but they are smokers. So that's mild. There is mild air obstruction. So they may not need anything, but you need to get them to stop smoking.
Oh, okay. All right.
All right? Now,
So they wouldn't get diagnosed as COPD then?
possibly not, because the FEV1 upon FVC needs to be less than 70%.
Okay.
But in this group B, they're shorter breath because the modified the scale, them shorter breath with MRC greater than 2. So that means that they're on level ground. I walk slower than people of the same age because I'm breathless, or I have to stop for breath when walking at my own pace. So they're shorter breath. So in this case now in group B, the CAT score is greater than 10 and them shorter breath. So I use LAMA plus LABA. This patient is group B. LAMA plus LABA is called Spioto. So it's a tiotropium bromide with a LABA. That is called Spioto. So LAMA plus LABA for group B. Remember, I could use a LABA alone for group A. Okay? Now, if they are in group E, them have exacerbation leading to hospital admission. Them need LAMA plus LABA plus ICS. So they need LAMA plus LABA plus ICS. Now, LAMA plus LABA plus ICS is marketed as Trilogy. And you see that on cable. We don't have Trilogy in Jamaica. So for these patients who are so bad that they're having exacerbations, them short of breath, the CAT score is high, the exacerbations are frequent, they need LAMA plus LABA plus ICS. Since I don't have Trilogy, I put them on the LABA plus ICS and give them the LAMA as a separate drug. So I would use maybe Seretide on these patients plus tiotropium or Spiriva. Understood?
Yes,
Because
ma'am.
I don't have
Yeah, because
Trilogy.
you don't have the trilogy itself.
I don't have to. I use LABA plus ICS and give them the LAMA separately. Okay.
So that based on the last
That-
point, if they don't have,
I'm not hearing you, Shanique.
okay, are you hearing me now?
Yes.
Okay, based on the last point, if their blood eosinophils are not that valued, would you leave out the ICS, inhale corticosteroids?
I would still put the ICS in because of the frequency of the exacerbations.
Okay.
But the guidelines, gold is online that you can read as well. They talk about if the peripheral blood eosinophils greater than 300. Yeah.
Doc, can you go back to what you did for group B?
LAMA plus LABA.
Okay, thank you.
So that's my Spiriva. What LAMA plus LABA is Spiota. The Spiota is available locally. It's put out by Boehringer Ingelheim.
So Doc, if the person
Yes.
fell in a group B and their eosinophils were greater than 300, would you then include the
I would be
ICS?
tempted to put them in, but the frequency of the exacerbations is so low that I would think carefully about it. But the guidelines suggest that you should, if the eosinophils is greater than that. But the exacerbations are not significant in this one.
All right, thanks, Doc.
So how do I follow? So I have an idea. Okay, let's recap. I've proven the COPD. They have done spirometry. FEV1 upon FVC post bronchodilator is less than 70%. In Jesus' name, them stop smoking. I've encouraged them. I've gotten them to stop smoking. But I have done my spirometry and there is significant airflow obstruction. They're having exacerbations and the shortness of breath they have, it's affecting their quality of life. When I do the CAT score, I realize that the score is closer, the score is high enough that the patient is, I need to, going to use it to put them in either class A, class B, or class E. Now I need to make sure that's going to guide what I use. Remember we said class A is the LABA alone. Class B is LABA plus LAMA or Spiota. And class E is LAMA plus LABA plus ICS. And they added it the peripheral blood eosinophils. The problem is that I can't get my peripheral blood eosinophil count. So I've put them in a class. How do I follow up these patients? Because my job is to reduce the exacerbations. My job is to make sure they're immunized. My job is to make sure they're using them puffer properly. My job is to make sure that I treat the comorbidities. My job is to make sure that I minimize all exacerbations. So I use my pulse oximeter to make sure they are comfortable. I check the inhaler technique. And if whatever I put them on there, whether it's the LABA or the LABA plus LAMA or the LABA-LAMA ICS, then I make sure I check adherence and that they are comfortable. I immunize them. I give them Prevnar vaccine. I give them flu shot, COVID, pertussis, everything. And I warn them that if there is a whole heap of air pollution when Riverton dump is on, don't come out of your house, wear a mask. Then I have to decide if they need oxygen therapy. So home oxygen is indicated when the ABG shows a PaO2 less than 55 on room air, or the ABG shows, it should be with, if the PaCO2 is less than 60, they have cor pulmonale, pulmonary hypertension, or they have polycythemia. Polycythemia is usually because of the low oxygen levels. This patient is going to need home oxygen. So home oxygen therapy, if the PaO2 is less than 55, if the PaO2 is less than 60, but they have what's called pulmonale, right heart failure, secondary to hypoxia, underlying lung disease. If they have pulmonary hypertension, if they're polycythemic, and if the SATs are less than 88%, these patients need home oxygen. I follow them up with either the LABA-LAMA, or if they have an exacerbation, sometimes I might need to use systemic steroids, especially if they have the exacerbation brings them into hospital. I may need to use steroids to help to control the exacerbation, plus treat any underlying infection that is there. Some of these patients coming in type 2 respiratory failure, the PCO2 gets high, I might have to use non-invasive positive pressure ventilation to bring the PCO2 down. There are patients as well who I will need to use long-term oxygen. And we used to do something called lung volume reduction surgery. So that would be like my patient with a bully. I would remove all of these. I would try to remove the bulla to improve his oxygen carrying capacity and oxygen transfer.
That patient, you would treat him as a group E?
Yes.
All right.
That
Doc,
same
can you
patient
repeat
with the
for
chest x-ray? Yes.
Yes, doc.
Doc, can you repeat for exacerbations? What do you give them? Steroids?
For the patients who are pretty bad, systemic steroids. Systemic steroids now is the IV Solumedrol. For acute exacerbations requiring hospitalization. So that is separate, from the inhaled corticosteroid. So they may be on the inhaled corticosteroid already, but they picked up some infection or some air pollution, which worsened the exacerbation. I have to put them on IV steroid to help them.
Okay, so just
I
to
usually
clarify,
use Solumedrol. I'm sorry, I didn't hear that.
no, I just wanted to clarify, if a known COPD patient presents to the emergency room in an exacerbation, their management is going to be giving them IV steroids, plus in
That's
the
right.
acute setting, just
Right.
that's it. We don't give them just inhaled steroids or any SABA or
It
LAMA at that time.
depends on the patient. If they're belonging to a group E, they may need the inhaled corticosteroids. But even if the patient is already on an inhaled corticosteroid and they come in an acute exacerbation that is bad enough, the SATs have dropped, I'm giving them IV Solumedrol, even though they were already on an inhaled corticosteroid. You understand that?
Yes, Doc.
Good. So if the patient comes in and they were already on the ICS and they have an exacerbation and the SATs have dropped and them distress, them getting IV Solumedrol. When the coast and the clouds have disappeared and they are better, I now assess the patient. If they were not on the inhaled corticosteroid before, I may need to put them on one when they're going home. And of course, you need to decide which patients need long-term oxygen therapy. Oh, that's it. Oh. Okay. That's it. Any other questions? That was long. Any other questions?
No, Doc.
All right. Well, I know that was long. You seem to have been interested. I know that was long. I pray that everything goes well for Una for the exam. All right. I see chats here now. Let me go deal with the chats. Okay. We don't read what? We don't, oh, I don't know what that one's saying. Asthma after bronchodilator. Oh my, I'm not reading that. Not fit for airplay. Asthma is reversible, hyperinflation. Okay, all right. That's it. All right. Any last questions anybody wants to ask?
Hi, Doc.
Yes.
Can you go over the spirometry for obstructive versus restrictive diseases?
All right. Let me, can you still see my share? Can you still see my screen?
Yes.
Okay, let me go back over to where's slideshow? Okay, from current sign. Okay. Okay. All right, let me show you the spiral. Okay, here it. So this is a spirometer. Okay. Now, patients with obstructive disease, FEV1 upon FVC, usually less than 80%. Okay. So here it is. This is a flow volume loop. The bottom part here, take a deep, 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 deep breath in and blow. And blow. This is the patient blowing out. This yellow line represents somebody who does not have any airflow obstruction. Notice that they are blowing all the way out. The scooped out blue or green line represents somebody who has airflow obstruction. So the FEV1 upon FVC is less than 80% predicted. If they have COPD, even when I nebulize them, when I do the spirometry after, the FEV1 upon FVC remains less than 70%. Now, the patient who has restrictive lung disease, nothing wrong with them airflow. They can blow. But the problem is the lung volumes are shortened. So the FVC is what is reduced. Okay? Whether the lung volumes are shortened because of obesity or the lung volumes are reduced because of scarring from pulmonary fibrosis, the FVC is what is lower than normal. But the airflow is fine, so the FEV1 is usually okay, but it's the lung volume that has been reduced. That patient has restrictive lung disease. So when you look at it, the volumes underneath here are small. Makes any sense?
So restrictive FEV1 is normal.
They don't have, patients with restrictive lung disease don't have a problem with airflow. The problem is the lungs are small. The lungs are reduced in size either because of obesity, chest wall problems, or scarring from pulmonary fibrosis. Okay?
Yes.
Doc, can you go back to the slide with Group B management, please?
That's group A.
Okay, thank you. And lastly,
Sorry.
you can go on, Shanique. Narrate that importance.
Yes, Shani.
Okay. Can you remind me what's the SpO2 target for the COPD patients and at what percentage you start to worry?
What is the SpO2 target for the COPD patient?
Yeah, because remember, theirs is normally lower than the 95 aim that we aim for persons that are normal.
Right. So we would be 96 and above. So if the SATs go below 90, I get anxious.
Yeah, they said the okay O2 level for COPD is 91, 92.
Anybody below 90 with COPD, I get anxious. So my cutoff would be about 90. If they're falling below 90, I get anxious. Now, there's one thing I should point out. That not every patient with COPD is a CO2 retainer. What's the normal CO2 range? What's the normal CO2 range on ABG?
35 to 45.
35 to 45. So if I see a patient with COPD with a PCO2 of 50, that patient is a CO2 retainer. Now, not every patient who has COPD is a CO2 retainer. The problem is that in the patients what is your drive to breathe and my drive to breathe? My drive to breathe is my CO2. When my CO2 goes above a certain level, my brain knows I must breathe. The patients who have COPD, who are CO2 retainers, their drive to breathe is hypoxia. They are accustomed to retaining a certain level of PCO2. So the problem comes when you put somebody whose drive to breathe is hypoxia, put them on 15 liters of oxygen, them going to breathe? No. So the patient, you carefully titrate up the oxygen. You don't hit them with 15 liters because the SAT is 90. You with me? You would gently titrate up the oxygen, maybe 2 to 3 liters via the nasal prongs to see what they do. But you don't use high flow like that. You don't use a high flow of oxygen. You don't give them 15 liters like that because the stimulus to breathe is hypoxia. If I give them too much, I take away the stimulus to breathe and they'll stop breathing. I confuse you now?
Wait, doc. So in
So,
that
doc,
case, they could be like probably 90 if they were below 90.
If the patient is below 90, I slowly give them 2 to 3 liters of oxygen, not 15 liters.
Yes, doc. But what would your goal be?
90, I want to get them 90 and
90.
above. Yeah. My
Okay.
lower limit is about 90. If they're going below 90, I'm worried. Because remember, what is the problem for hypoxia? You talk about cor pulmonale. Why do they go into cor pulmonale? If they are hypoxic, what is the problem? If they are hypoxic, what is the problem? They're going to get pulmonary vasoconstriction from the hypoxia. When the pulmonary vasoconstriction occurs, the pulmonary vascular resistance increases. When the pulmonary vascular increases, it causes pulmonary hypertension. When pulmonary hypertension occurs, it puts back pressure on the right ventricle. When it puts back pressure on the right ventricle, the patient goes into right ventricular failure. So this is why I don't like them going below 90% because I don't want them to go into right heart failure as a result of the hypoxia causing pulmonary vasoconstriction.
Okay, doc. Just I had a question. In the real world, doc, when giving patients with COPD oxygen, you're saying that you usually give them via the nasal cannula and titrate up versus
That's
like
right.
what we see in the literature where they tell
Yes.
us, COPD patients must be on Venturi. That's not really what's done.
Or the Venturi
Or
mask. Yes. Yes. But
okay, so
we don't have a lot of Venturi in the house. I've not seen
got
a Venturi
you.
in the hospital for a long time. So it's either
Okay.
Venturi, which tells you the Venturi is a special mask that has something in there that tells you when I put it at 10 liters on the wall and I use this blue thing, the patient is only getting 30%. So the Venturi comes with a code that it has, which is a color-coded thing. So it tells me how much oxygen I'm delivering.
Okay, I just wanted to know if the Venturi was like an ICU, was it just a situation where we
No,
don't have it
Venturi
out
masks
here?
were on. We used to have Venturi masks on the wall on the walls when I was a student. I couldn't tell you when last
Okay.
I saw one.
Okay, thanks, doc.
Doc, last question from me. When you're titrating, when you're on the ward and you're titrating up, how long after do you reassess
I use my
to know that
SATs.
you, huh?
I use my SATs. You mean titrating up the oxygen?
Yeah, so you put them on your 2 to
I
3
start them on
liters.
2 to 3 liters. I'm monitoring the SATs. I'm monitoring my SATs if my SATs are going up. And while I'm also monitoring the SATs, I'm looking if the breathing is okay. If the patient is breathing okay, the SATs are okay, I am fine. I can even do a blood gas if ICU will allow me to see where I am. But the patient must be breathing.
Okay, so we see a change within couple minutes.
Within at least half an hour.
Oh, yeah. All right, thanks.
Doc, I have a question. As far as giving them, you said don't give them the 15 liters of oxygen. Is it that would put them in like respiratory distress? Could we just worsen them with doing that?
No, what it will do is take away the drive to breathe. We said that the patient who is a CO2 retainer, and I cannot overemphasize the point, not every patient who has COPD is a CO2 retainer, but you happen to have the one who is a CO2 retainer, and you give them 15 liters of oxygen. That CO2 retainer patient stimulus to breathe is not CO2, it's hypoxia. So when you give them 15 liters of oxygen, you take away the hypoxic drive, so them stop breathe. So you have to titrate the oxygen slowly in that instance.
Hi, Doc. So you're saying for those patients who are not CO2 retainers, they
You
still have
can give them the high flow, but you still, yes, you can give them higher flow of oxygen, yes,
okay,
if
and they still
needed,
have
and
their
you monitor the SATs.
so they still have their hypercapnic drive.
They will have a hypercapnic drive, yes, but
Okay.
you monitor the SATs.
Okay, thank you.
All right? This must be one of your
Excuse me,
longest
Doc.
sessions. It's 3:45.
Hello?
Yes, I'm here.
Okay, I was just wondering, how do you know who is who? Like, who's the retainer versus who's not? Is it that
The
you don't
blood
know and you
gas is
just...
the blood gas is the only thing that will tell you. And let me see who is firing. I don't have a blood gas, but I have the UNEs. And the patient, what in the UNEs will tell me this patient is a chronic CO2 retainer. Okay, this is your final question. Olivia said to me, how am I going to know the patient is a CO2? I don't. A blood gas would tell me, but I don't have a blood gas. I have the UNEs. I have the UNEs from Kempath. What in the UNEs is going to tell me, hello, this patient is a CO2 retainer?
Bicarbonate?
Who said it? Javon?
Yes.
Yeah, that's correct. Normal bicarb 24 to 28. So if I see a bicarb of 30 or 30 odd, this patient is a CO2 retainer. So I would titrate the oxygen slowly. Okay? All right?
Oh, thank you, Doc.
All right, take good care. Every blessing to everybody. Do all that you can. Work hard and we'll see you in exams. Okay? Have a good weekend.
Thank you, Doc.
Bye.
Thank you, Doc.